Good afternoon, friends. We are here for the live case sponsored by Merrill Life Sciences, and of course, we have to align for the future with the Myval THV series, and we're going to discuss step-to-step implantation techniques, but also the evidence around the Myval. Here, my conflict of interest. We're here to learn about the novel balloon-expandable Myval THV series and to update ourselves on the clinical evidence around it. We want to understand the best practices, the step-by-step implantation, sizing, and implantation in the best possible manner for our patients. And we want to update ourselves on its real-world experience through patient registries and large center experiences. My name is Ashok Seth from India, and with me is soon to be taking that chair is Dr. Wael Al-Kashri from Saudi Arabia. The operators are going to be Hatim Al-Lawati and Adil Jabri from Oman. We have Cath Lab Medical Coordinator in Khalid Saidi. We have the discussants here as Muhammad Muknaini. We have Abdul Rahman Al-Mughari, Nicholas Dementil, Atta Ferazi, and Kristen Terkelsen. Speakers, Andreas Bombach and Khalilpur Ahsan, and they're also on the panel here. Residual analyst is going to be Saleh Kauj, and on-stage medical coordinator is Abdullah Al-Sabia. So that's the session team we have in front of us. Remember, use your app, be interactive, ask questions, and they're certainly going to be picked up on that iPad, and we'll do our best to answer them at the appropriate time. There are standing microphones. Let's be interactive. Let's talk to each other. Let's learn from each other, and certainly bring up questions as the discussion session and the discussion and debriefing happens. Keep the PCR at your fingertips. Questions in the live chat, speakers, names, roles, all are here. And of course, it's become an integral part of our life for the last 2 days. With these words, I think we should go on to the talk. And I would then take you through the Myval itself, the design philosophy, and the real-world experience. So here again, my potential conflict of interest. You all well recognize the Myval. It's a novel balloon-expandable valve. It's had 20,000 implants globally in 80+ countries and is directly mounted on this navigator delivery system. It gets mounted between the two stoppers here. It's a snug fit. This balloon has 3 markers, a central marker and 2 markers at the ends. We also want you to understand that this is a very flexible delivery shaft of the navigator system. And when this valve is crimped, it creates a unique fluoro appearances of dense bands and light bands related to the V hinges and the vertical connectors. And this light and dense bands aids in appropriate and accurate placement of this valve. Here's the annular plane, as you can see. And when the valve is inserted, we would like to implant it at the annular plane, the second dense band at the annular plane, which is a 70-30 positioning of this THV. When the valve expands, with a 22 to 24% foreshortening, it would end up at 80-20 or 85-10. So that's what we want to do, and therefore it aids this accurate positioning, as you would see here. And you would see some of this being demonstrated, and I'm sure being demonstrated in the live case as it is performed. It goes through this 14 French lubricious introducer sheath. All sizes from 20 to 32 go through the same sheath, which expands. And what's a very important aspect is that through this sheath, we can actually withdraw an undeployed valve, an unexpanded valve through the sheath, which is unique to this valve as opposed to the other contemporary self-expandable, balloon-expandable valve. Available in 9 sizes from 20 to 32 millimeter diameter, covering an annulus area of 270 to 840 and even greater. And I think this case represents, and perhaps you will see it in the live case as well being demonstrated, is that this is how intermediate sizing of this valve helps. He is a patient who has a 26.7 millimeter annulus diameter. He has heavy calcium protruding into the annulus as well as the outflow tract. If we go for a conventional 29 millimeter transcatheter heart valve, it would end up being 18% oversized, which might not be good for this anatomy, thereby having risks for root injuries. And of course, a 27.5 intermediate sizing enables us to be appropriately oversized at 7%, and that therefore respects the anatomy, preserves the geometry, and close to 50% of the valve sizes used across the world are intermediate sizes. Of course, the extra large size adds to this whole range, the 32 millimeter, which is compatible with the 14 French sheath. 7 to 10% of the valves across the world are extra large sizes being used. And of course, this is a very representative case of an annulus diameter of greater than 34 millimeters, an area of approximately 930, which is treated with a 32 millimeter valve plus 5 cc of Myval with a perfect result, a 90-10 placement, and no complications. This valve allows for commissural alignment in a novel way. It's called the octa-align technique. You would probably see it being demonstrated in the live case today. And while I won't go over the details of this case, you understand that it comes from, it is based on the multi-slice CT analysis, knowing where the position of the right coronary artery is, aligning the commissure to the right coronary artery when it's mounted. The valve flips over to 180 degrees, and therefore commissure normally comes on the opposite side of the THV, and therefore commissural alignment is achieved in more than 80% of the cases, as has already been published. So it's easy to practice and doesn't require additional softwares. Landmark study, the major pivotal controlled prospective study presented at the PCR, looked at Myval and the composite endpoint against the contemporary transcatheter heart valve series with a primary composite endpoint at 30 days of non-inferiority to contemporary valves. Myval proved itself to be non-inferior to the contemporary valves at 30 days, and this was published in the Lancet. Predefined statistically powered subset analysis of comparing Myval to Sapien and Myval to Evolute series in the same study was presented at the London Valves and again demonstrated non-inferiority to the contemporary self-expandable series and the balloon-expandable valve. Well, I think the biggest point in this study, the biggest message in this study for me certainly turned out to be this very surprising results, which demonstrated that the effective orifice areas of Myval were larger than that achieved by the other self-expanding valve, in this case, in the Sapien, which was used in the study. And certainly in the sizes, in the larger sizes, it was close to the self-expandable Evolute series in terms of effective orifice area. So Myval gave larger effective orifice areas, and even the smaller Myval was larger than the next size of the other balloon-expandable valve. That is extremely important. So this slide sums up the unique features of Myval, the direct crimping, the landmarks, the reduced foreshortening, the octa-align technique of alignment, for commissural alignment, retrievability, 9-inch sizes, intermediate sizes, extra large size, and the 35 millimeter size, which is being researched on. Thank you very much for this attention. Any questions or any points that one would like to address? Anything that you have in mind? If not, you're going to see a lot more of it, and there's going to be discussions around Myval, so I'd rather move on to Christian Torkelsen for his COMPARE TAVI. He's the principal investigator of the COMPARE TAVI, which was presented at the London Valves. Over to you, Christian, for this study.
So there will be a discussion at some stage here, so you can have your question ready after we finish a couple of presentation, I think we can take your questions.
So I will present to you one-year outcome from the Compare THV trial. These are my conflict of interest. We launched the Compare THV organization to compare new transcatheter heart valves against best-in-practice contemporary valves. Our aim was to randomize all comers so that we could generalize the results. We wanted to provide short-term safety data, but also long-term durability data with 10-year follow-up. The first study we launched was Compare THV 1, where we randomized between SAPIEN 3, SAPIEN 3 Ultra, and Myval and Myval Octa-Core. The inclusion criteria were that all patients who were eligible for balloon-expandable valves could be randomized. The center should have a volume of more than 75 patients a year, and each operator should have implanted at least 15 of each valves being compared. The primary endpoint was a composite of death stroke, moderate or severe aortic regurgitation, and moderate or severe hemodynamic valve deterioration at 1 year. And according to WAC 3, you cannot evaluate valve deterioration until after 1 year, which is why we chose 1 year as the primary endpoint. We also had Bonferroni-corrected secondary endpoints, so if non-inferiority was proven, we would also see a THV-related complications, successful implantation of the planned valve, and new pacemaker within 1 year. Other secondary endpoints are hypothesis generating only and exploratory. This is the power calculation. We needed 1,002 patients, and to take into account dropout, we aimed for 1,062 patients. In reality, we didn't have any patients who withdrew consent. The participating centers were 3 THV centers in Western Denmark. They all have a long history of performing SAPIEN implantations. We have a catchment area of 3 million inhabitants. We do 750 THV a year at these 3 sites. This is the inclusion. We started in June 2020 with the Myval as comparator. Then we were on hold for 1 year because there were legal battles between Edwards and Merrill. And when we resumed inclusion in August 22, we used the Octa-Core instead of the Myval. We finalized enrollment in November 2023, just 13 months ago. We actually included 77% of all patients being treated at the sites. They, of course, needed to give consent to randomization. We included both valve-in-valve and bicuspid anatomy. We included acute and subacute cases. This is the patient population. They were 82-year-old males, 60%, and there were an STS score of less than 4 in 80% of patients. This is the primary endpoint. As you can see, the primary endpoint occurred in 13% of patients randomized to SAPIEN and 13.8% randomized to Myval, which means that Myval was non-inferior to SAPIEN, as you can see here. And also here, where you can see that the upper confidence interval does not cross the non-inferiority margin. So we conclude that Myval THVs are non-inferior to SAPIEN regarding the composite endpoint of death, stroke, moderate or severe regurgitation, and moderate or severe valve deterioration at 1 year. If we look at the individual components of the primary endpoint and also the Bonferroni-corrected secondary endpoints, we see that the number of patients with moderate or severe regurgitation was very low in both groups, 1.2 and 3.9%, but overall it was in favor of SAPIEN, which also was the case for primary pacemaker implantations. Whereas if we look at the exploratory secondary endpoints, we could see that patients' prosthesis mismatch was favored in Myval, which means that they had a larger effective orifice area for all valve sizes and all annulus sizes. Whereas Sapien-treated patients had less atrial fibrillation and also less bleeding. So this compare one is the largest one-to-one comparison of any two valves to date. It is also the first all-comer trials, so we think it can be generalized to daily clinical practice, and these are the essentials to remember. Thank you.
Thank you. Questions from the audience? Just a reminder, please put them right here. I think we have a question coming up. Yes.
I'm Dr. Ehsan from Rajai Center with my friend Dr. Firuzi. We have implanted like 500 cases of Merrill up to now, and I believe the pacemaker rate is pretty much less than what we actually got in the trial. It is like about 10%, I believe.
Interesting.
So in the landmark trial, it was 15%, and in our study, it was a little higher. But it was also evident from subgroup analysis that the rate of pacemaker was even higher with the octa-core. So I think if you use Myval, you will probably have a little less pacemaker.
You should write it up.
Yeah, thank you.
So, any other points? Christian, just one further point. You are doing further analysis on the pacemaker.
Yeah, we have actually...
Depth.
We have a sub-study where we have...
Sizing, etc.
Yeah, we have more than 500 patients where we have 1 month follow-up CT. So we are currently looking into the depth, because you need both a pre and a post-CT scan to evaluate the exact depth, also the eccentricity and the size of the valve in the outflow tract. So we will come up with additional analysis to find out what is the cause of this increased pacemaker. And maybe it's just a deeper implant and then we should just correct it. But also we have to remember that in the beginning, Merrill advocated that we should oversize like 10%. I think we should be careful not to oversize more than 5%. So less oversizing, high implant is probably the solution.
Thank you. We'll go on to Val's patient presentation. Slides,
please.
I'll just do that for you.
So this is the case presentation for the case will be live in transmission. 82-year-old gentleman admitted to a peripheral hospital with acute heart failure and anemia requiring blood transfusion. 2024. Gastritis, severe aortic valve stenosis, ejection fraction 60%, referred for further evaluation. Background hypertension, type 2 diabetes mellitus, dyslipidemia, chronic kidney disease, and obesity. This is the cardiovascular risk factor: hypertension, diabetes, and high cholesterol. Clinical presentation: the height is I think I think this one is like anyway 80 kg. Body mass index is 34.4, and frail and limited mobility due to osteoarthritis. Medication: aspirin 75, omeprazole, furosemide, atorvastatin, pisopro, and gliclazide. Hemoglobin at the time of the procedure 10.6, troponin not done, creatinine 11. ECG: incomplete right bundle branch block. Transthoracic echo: normal LV size, ejection fraction 60%, no regional wall motion abnormality, grade 2 diastolic dysfunction. RV normal in size, TAPSE 22, dilated left atrium, mitral annular calcification, mild MR, mean mitral valve gradient 3, tri-leaflet aortic valve, mild AR, severe aortic valve stenosis, mean 45, peak 72, aortic valve area 0.8, trivial TR, normal PA pressure. His coronary is refilled normal coronaries. So in summary, 82-year-old, frail, limited mobility because related to osteoarthritis, the chronic kidney disease, anemia, dyslipidemia, and hypertension, heart failure presentation, class 3, ECG, incomplete right bundle branch block, echo, 60% ejection fraction, severe AS, unobstructed coronary artery, Euroscore 1.78%, ST score 2.5, and the intended procedure today is the live transmission with the octacorn platform.
So, Saleh Kaj, why don't you come up and present to us the CT analysis so that we can have a discussion around the patient?
Good afternoon, everyone. So I'm going to go over the CT analysis for this case. So this is the annular plane, which showed an area of 339 millimeters square. Perimeter is 65. So it's a small annulus. Moving to the LVOT, it's almost similar measurement of the annulus. Again, small at a distance of 3 millimeter depth. And he has a wide sinuses with a mean of 29 millimeters. This is the calcification distribution, so you can appreciate mild to moderate calcium with almost equally distributed in all 3 cusps, maybe more dense on the left cusp. Moving to the coronary height, we have adequate height of the right coronary artery, 17 millimeter, and 13 millimeter height for the left main. This is the coplanar angle. STJ is very wide, area of almost 800, diameter in the range of 30 millimeter. Cusp overlap view. And this is the membranous septum length, which is very short, which increases the risk of requiring a permanent pacemaker, as the patient also has a right bundle branch block as well. So the area goes within the range of 21.5 Myval platform. So how to calculate the percentage of oversizing? If we choose a 21.5, the nominal area gonna be up to 363. So we take the difference between the annulus of the patient from the nominal, and then we divided the difference by the patient annular area and multiply by 100. So we have a 6% oversizing of the annulus if we use a 21.5. What about using a 23 Myval? So we will end up with 22.4% oversizing, which is quite too much oversizing, and the more you oversize, the more you're going to touch the conduction system, and the patient might require a pacemaker. This is the height of the 21.5 frame, so it's an 18.3 millimeter in length. The closed cell is 8.6, and the open cell is 9.7. And so we suggest the depth gonna be 90% aortic and 10% ventricular to minimize the risk of pacemaker. Moving to the peripherals, large and adequate peripherals with a minimum diameter of 7.5, very mild calcium, very minimal tortuosity, and the bifurcation is below the femoral head. So this is a virtual valve showing the, if we use a 23 millimeter valve, it seems to be slightly bigger than the annulus. What about the 21.5? So just to have an estimation and an idea about the boundaries of the valve within the annulus. So in summary, small annulus, adequate sinuses and STJ, moderate calcium with the valve, adequate coronary heights, good peripherals, and very short membranous septum, right bundle branch block. So most available valves can fit into this anatomy. We need to choose the proper depth of the valve to minimize the risk of pacemaker. Thank you.
Thank you.
Thank you, Saleh. That was wonderful. I mean, that was quite clear. Let's have a discussion around the table. We've got a large patient and a small valve. Andreas, great interest in small annulus recently, especially with trials being done specifically for this. What's your choice of valve in a small annulus?
Yeah, so the data you're referring to, that's the SMART trial where the SAPIEN was compared with the Evolut platform.
Yeah.
And the basic outcome was that clinically there was no difference after 1 year, but in terms of patient prosthesis mismatch and valve failure, there was a higher rate of that in the balloon expandable. And hence, a lot of people conclude that there should be a role for self-expanding supraannular valves in these cases. But of course, we can argue that in some cases, a balloon expandable with a short frame and ideal sizing could be an alternative.
Right, which brings us to the point, yeah, is there anyone around the table who'd consider things differently?
Yes, I think it's important that our data, our knowledge is for prosthetic mismatch in TAVI based on surgical experiences, because in that study, after 2 years, they didn't see any differences between the outcome in patients with balloon and self-one. And we should keep in mind in this patient with incomplete right bundle branch block, the rate of paces with most of self-one will be higher than balloon.
Yeah. Right. So Abdurrahman, the multiple risk factors for heart block here. What's your thought about the depth and in presence of bulging septum, relatively bulge septums?
Yes.
Now we are like.
In our center, to be honest, for patient with bundle branch plaque, for patient with long PR interval, especially for right bundle complete or incomplete, we try to deploy it we checked in also cusp overlap other than coplanar. We try to be a little bit higher. Yeah.
So Nicholas, pacing is an important aspect of part of the procedure. And of course, there's been an increasing trend to pace on the LV wire and not put a temporary wire in. How would you handle this case? Would you put a temporary wire? What do you expect?
Yeah, and I'm personally using the pacing of the left ventricular wire technique for almost all my procedures. But in that setting, with the predisposing factors we've seen, I would also put venous access and RV pacing link from the beginning, because there's a high chance that the patient may have a third degree AV block as soon as we cross the aortic valve.
Which brings me to a very important aspect, sizing. And Kristen, you just related you had some comments in your talk around sizing. Sizing is crucial. Should we be getting to, this is mild calcium, small valve, small annulus? Should we not be getting to 10 to 15% oversizing in this case to get the maximum EOAs and least PPMs?
We never oversize like 15% anymore, also not with the SAPIEN. I think you have better hemodynamics with the Myval compared to the comparator SAPIEN. I would still go for the 5% as you also, I think, was aimed at in this setting, and then maybe a 10-90% in implantation, very high implantation. Even if you go for 0, it's also okay.
And that way get the maximum effective orifice areas. Please
Just
go
one
ahead.
comment. The aorta is horizontal, and if you want to implant it 90-10, what's the risk of embolization, given that you don't have much of calcium in the annulus?
Yeah.
Fair points, and we're going to see exactly how that is done.
Okay.
I'm sure the operators are going to keep exactly those issues in mind.
Yeah.
I think we'll move on to the operator strategy. What are the operators going to do? So could I have the slides as to what the operators plan to do? So the operators, as we've earlier introduced, are Hatem Lawati and Adib Jabari. A great team with them, as you see here. We welcome them. These are the conflicts of interest. The procedural strategy is clearly outlined: a 14-French python sheath from the right femoral artery. The contralateral artery and vein are going to be punctured. 6 French pigtail catheter from the left femoral artery and the left femoral vein with a pacing wire. Cross the valve, implant a 21.5 millimeter wire valve prosthesis. Consider a higher implant, as we have discussed. No predilatation is going to be performed. It's going to be a direct implant, keeping in mind the low calcium. The tools and techniques, well, the right femoral artery is going to be pre-closed with 2 proglides. The aortic valve is going to be crossed with an AL1 catheter and an 035 straight-tip metal wire. The LV wire, the delivery wire is going to be a Safari, small or extra small. The valve we've just explained is a 21.5 millimeter Myval. And if post-dilatation is required, it will be obviously with the same balloon, 1 to 2 ml extra. With that, we're ready to go live. Hatem and Adil, you're on. We see you.
Greetings, everyone. Hi. Can you all hear us?
Absolutely. Loud and clear.
Good afternoon, Prof. Set. Good afternoon, everybody, and welcome to this live transmission from the National Heart Center at the Royal Hospital in Muscat. I'm Hatem Lawati, and joining me is my colleague, Dr. Adil Al-Jabri, and assisting us with this case from the nursing team are Maryam Al-Ma'mari, Zakaria Al-Ma'wali, and Ahlam Al-Balushi, and from the technical team, Yusuf Al-Farsi, Salim Al-Muqbali, and Shihab. And our anesthesiologist today is Dr. Haifa Zabi. So the details have already been presented. I'll bring you up to speed with what we have done so far. If we can just maybe focus on the working field. So we have obtained ultrasound-guided access to the left femoral artery and vein. This is a 7 French sheath through which we have a pigtail catheter. This is a 7 French sheath through which we have a temporary wire, which is now secured at the RV apex. We've already tested the thresholds and we were happy with that. Another ultrasound-guided access was obtained in the right femoral artery. This was pre-closed with 2 crisscrossing ProGlide devices at 10 o'clock and 2 o'clock. After that, a 9 French sheath was placed in, and over an Amplas extra stiff wire, we've advanced the 14 French Python sheath. This was done after pre-dilating the tract, the common femoral and iliac arteries with a 14 French dilator. After placing the sheath in, the sheath itself was dilated again with an 18 French dilator to ensure that we'll have a seamless delivery of the valve to the aorta and the annulus. The patient has been quite stable throughout the procedure. He, as you can see on the screen, remains in sinus rhythm with a normal PR interval, but a right bundle. And we are ready for the next step, which is crossing the valve, documenting hemodynamics, unless there are any burning questions.
Are there any questions from the panel?
No.
None whatsoever. Please proceed
Straightforward.
and demonstrate the steps.
So we can just show them what we've done so far. Can you play from the beginning, please? So this is the arteries being dilated with a 14 French dilator. Next, please. This is the sheath coming in, very smooth entry into the vessel. And this is the 18 French dilator inside the sheath. This is going to be our working view.
Is that a balloon tip pacing wire? Do you use a balloon tip pacing wire, or is that a routine non-balloon tip wire?
It is a balloon tip pacing wire, but once we secure it in position, we deflate the balloon. So now the balloon is deflated.
Mm-hmm.
And as you can see, this is going to be our working view as identified on the CT analysis. This is an LAO8 caudal 10 with a reasonable overlap of the nadirs of all three cusps. The ACT was just checked. We are above 300 seconds. We have our AL1 diagnostic catheter in the proximal aorta. The pigtail is in the non-coronary cusp. I'll just aspirate first, please.
So while you're going to do this, and you did this in a coplanar view, what about you do not practice the cusp overlap view for balloon expandable in this case, especially where you really want to be shallow to the membranous septum? How do you want to plan this?
Maybe I'll speak on behalf of Dr. Hatem while Dr. Hatem tried to cross. So yeah, actually we are used to do both in this center, balloon expandable and self-expandable.
RAO, please.
And for self-expandable, usually we go with the cusp overlap. Balloon expandable, usually we still stick with the coplanar view, the classical three cusp overlap. In this particular case, we thought about using the cusp overlap, but actually we didn't get the good angles, and the cusp where the LCC and the NCC were, or sorry, the RCC and the NCC were not overlapped very well. So we said we'll just use the coplanar view.
You got across the valve very nicely, and in 30 seconds, could you tell us and the audience as to what are your tips and tricks to go across the valve, or is it just trial and error?
So what we've learned to do with TAVI cases that we've done is we try and understand the motion of the leaflets and the differential motion of the calcium. We find that the LAO projection, LAO30 is the best view to do that. And oftentimes you're able to identify an opening between the leaflets that you then target in the LAO projection instead of randomly poking at the valve. I mean, after all, this is a calcified valve. It's an elderly patient, and you want to minimize the risk of embolization. Having said that, I think we're blessed with the panelists today, and I think it's our lucky charm to have you all on the panelists and Austin very quickly. We're showing you the hemodynamics. These are the simultaneous pressure tracings. One from the pigtail catheter, which is at the non-coronary cusp, and that is the purple line, and one from inside the ventricle, and that's the yellow line. Can we measure the simultaneous pressures, please?
Yes, we see that gradient.
Yeah, so the main gradient is 59 millimeters mercury, and the LVDB is around, it's below 27.
And just to demonstrate one thing, we'll just try and do some ectopics, and you see the post-extrasystolic accentuation, which is quite dramatic. So we're truly dealing with a very tight valve. I think next we're going to go ahead and put in our Safari wire. Can you push the table away from me, please?
Hatem, what size of the Safari wire you are using?
We're using the Safari small.
So is that your choice normally, and how do you decide? Is that your usual wire to use? Is there specifically any anatomy that you'd like to use extra small Safaris? Because yes, a lot of Asia uses extra small rather than small Safaris. So do tell us a bit more about about why.
So our experience with the Safari wire, I have to say, is in its relative infancy. We've tried all the other wires, the Confida wire, the Inouye wire, and before that, the manually curved Amplatz extra stiff. We've noticed that the Confida and the Inouye tend to trigger a lot of ectopy, and we've oftentimes had difficulty securing them in a good position. But with the last few cases we've done with the Safari Small, we seem to always get a very stable position. You might have noticed that I didn't need to exchange to a pigtail and then put the stiff wire. The wire just curves seamlessly inside the ventricle without any issues. And it's in a very stable position with hardly any ectopy.
Right.
Ideally, we should be using, like mentioned, the extra small. A lot of our patients are severely hypertrophied in their ventricles, but this one seems to work fine as well.
We'll have your questions during the discussion. There's going to be an audience interaction after the live case. You know, while you're doing this and you're going to soon have the valve across, you can tell us the steps. You don't want to interrupt that. But I was just also going to ask you at the same time, do you pace over the wire in many of your cases?
We've tried it in a couple of cases, and to be very honest, we didn't get consistent pacing results.
Okay.
And when you're using a balloon, you'll probably get away with it with a self-expandable valve, where you want to pace just from the point of view of stabilizing the prosthesis as you are deploying it. But when you have a balloon-expandable valve, you want more consistent and predictable pacing. So we opted for a transvenous pacemaker here. And let's not forget, this is a patient who is high risk for complete heart block after valve implantation. So another reason to consider transvenous pacing.
So we're watching you continue the step by step.
Yeah. Can I see the tip of the guide catheter, please? Open wide. Open wide. Open wide, top and bottom. Okay, so we have a 21.5 millimeter Myval prosthesis that's crimped and aligned. We're delivering it now through the sheath. Very easy delivery. As you can see, I'm hardly pushing.
Their questions on the through the app. We'll see them and we'll address it if it's related to the case. Right
Can
up
you go
front.
LAO, please? Table towards me, please. So on the CT scan, you might have noticed that there is an acute angulation at the junction between the arch and the descending aorta. This is the part in the aorta that we're going to be a bit careful with. So as we come close, we're going to flex and apply a little bit of tension on the wire.
Yeah, keep tension on the wire, guys.
Yeah, I'm tension. I'm flexing now.
Okay, so it went pretty smooth.
So there is
And we're ready to cross.
Have they dilated the sheath? The answer, yes, they dilated earlier.
To the working view, please.
Okay. Pro-planar view. And we are ready with this.
So we're in the LAO8 caudal 10 projection, which is our deployment view. And as discussed, we're going to aim for a high implant. So typically you want that middle marker to be just a millimeter or two above the annulus. But we're probably going to start, this is a little too high, I think, maybe here. But we'll take an injection and confirm that this is the view we want to implant in. We're going to have to work quickly because the patient's already hypotensive. So can we get ready for the injection? Yes. Ready?
Okay. Yeah.
Inject, please.
So there's a lot of aortic regurg.
I think I'm going to start implanting in this view if there are no objections in the
Can you
panelists.
modify the view because this view is not
We
aligned?
will let you carry on and implant it and then talk to you. So you can concentrate on your implantation.
So your big tail is not touching the annulus, Hatim, in this injection. So you have to take this in consideration for the depth. Yeah.
Can we review the image again, please?
Can you look back at the images?
Play the
Previous one.
the previous injection, please. Okay.
So the big tail is not attached.
Now I've repositioned it. Okay, so pacer on, please. Pace at 120, 140.
You want to go deeper, Hatem, or you're fine?
160, 180. Okay. Go up. Inject, please. Inject. I'm happy with this. Go up. Full inflation. 1, 2, 3, 4, 5. Balloon down. Pace at 100. Take the balloon out. Yeah.
So yes, that was a perfect positioning that you felt that you wanted.
Let's just wait for his pressure to recover.
Yeah.
Please. Okay, we'll park the balloon here, wait for him to recover. He is already recovering. And slowly come down on the pacer rate. And stop pacing.
Give me the J1.
So as you can see, he has developed what looks like a complete heart block, I think. Yeah.
Which is expected, you know, like some advocate to put a pacemaker before, you know, like right, all the recipe for heart block is here.
Yeah. And just leave him pacing at 60. So this is despite all the precautions taken with the high implantation and the CT analysis. Okay. It's time for us to
Shall we take the pigtail from there?
do some hemodynamic studies.
Correct.
So
There's one aspect, you know, while you're going to do all that, is also go back to your shoot, the aortogram, when you place this valve. And that's going to be interesting for us to understand and talk a bit more about it. We didn't want to disturb you at that time, but it's always very educational to review that while you were positioning it.
So Hatem, before you do injection, just remove the parallax, you know, and give us the...
Yeah.
Yeah, we'll measure hemodynamics.
Yeah, in fact, what we'll do is we are going to remove the parallax, but the first thing we'll do is get some hemodynamics.
Yes.
So let's take the navigator delivery system out. Yeah. Just 1 second. Yeah. All right. Okay. Yeah, go ahead. Yeah. Can I get a pigtail catheter, please? Just push the wire forward, please. Push the wire, please.
Yeah. You got the wire?
Okay. All right. Okay. Right.
Yeah. Pigtail ready? Just adjust.
Let me just adjust the wire. Let's have the pigtail, please. Yeah, just give me the pigtail, please.
Pigtail.
Let's try and go a bit more caudal and see if we can take the parallax away while we're waiting for the pigtail catheter to come.
So while you're doing that, we're going to have some discussion.
That's it.
And then get back to you once you got your pigtail.
Sure.
So Nicholas, your preference, coplanar versus cusp overlap for shallow implants?
Yeah, each time the right-left cusp overlap view is doable, feasible regarding angles, I tend to implant the valves in that view, especially in that situation where you run 3D to target a high implant. But sometimes, as said, it's not even feasible.
Yeah. So, Dr. Abdurrahman Mugheri, do you use the cusp overlap in your... you do a lot
balloon expandable? Yes, we use it very common because sometimes the anatomy will force you to go to this one, and sometimes you choose it by default or by selection because you need the most accurate point to position your valve and which is reproducible, either the coplanar or the cusp overlap, which works with both self-expandable and balloon expandable in the same time.
What about using hybrid, like a blend of both?
Yeah, common. We use it common.
Christian, do you pace over the wire? Oh, please, go ahead, yeah.
The cusp overlap, we use it for self-expandable, but for balloon expandable,
Microphone, yeah.
so the co-planar, we use it for the balloon expandable, but cusp overlap, we use it for the self-expandable.
Christian, do you find pacing over the wire, LV wire, which is, I guess, your usual practice, better with a small Safari versus extra small? And does that loop of a Safari matter for the contact on the LV, and is it more predictable?
So to be honest, we always used a extra small Safari wire, but we actually went away from pacing on the ventricular wire again, not because we had any issues, but I have seen several times also when proctoring that there are pop-ups. So I think we should be fair to say that it is more secure to pace on a lead from the vein if you do a balloon expandable.
Yeah.
Of course, you can do it on the wire, but if you want to be 100% safe, I would still pace on a ventricular wire, lead from the vein.
So you want to say, Artem, you want to say something?
So I just wanted to share the hemodynamics when everybody's ready.
Yes, we are. The
Okay.
stage is primarily yours.
So again, we're showing you the two hemodynamic tracings, the purple from the proximal aorta, and that's the pigtail above the prosthesis. And then the yellow line is from the pigtail catheter across the prosthesis inside the LV. The systolic curves are overlapped, and the mean gradient is a single only 1 millimeter mercury. The left ventricular end diastolic pressure has not increased, and as you can see, the aortic diastolic pressure is 60 millimeters of mercury. So we don't expect to find significant AI, but we'll confirm it with an injection. So I think this is a very reasonable result from a prosthesis implant standpoint.
Yeah, so you have no gradient on a 21.5 millimeter prosthesis, which is excellent.
Show us the injection now, Hatim.
So I'm going to remove the pigtail catheter from the LV, and then we'll do our injection
And center your
with the
valve.
catheter outside.
Center the valve, like to see the injection in better way.
We will.
He's good.
We will. So let's just keep it there. Yeah. Leave it connected to pressure because we'll disconnect this one. Right? Yeah.
So of course, you're now going to give us the aortogram. What about your echo colleague, your non-invasive colleague? Did you rely on him? Do you first do that? Do you not do it at all? How do you go about it? I'm sure he's somewhere around you.
He is somewhere around us, but to be very honest, our practice is relying mostly on hemodynamics, and we will often have an echo machine on standby, mostly for suspected complications. But we don't rely routinely on echo post-implantation to check our results. Okay, so can we see more LV, please? So we're going to try and select a view where where the aorta is out of the way. How about an RAO projection? And let's try and take the parallax away. So maybe try caudal. Keep coming. Yeah.
Yeah, you'd have to go a lot caudal.
Yeah. Keep coming. Almost there.
So why are you doing this view? Please tell us. And not the LAO with the parallax removed.
So just wanted to take the aorta out of the way. As the contrast opacifies the aorta, it flows down the descending aorta. Sometimes it masks our ability to understand where the AI is coming from, whether it's paravalvular or valvular. Is there any chance we can get more caudal? And perhaps center the, okay, can you show us more LV, please? So we can't remove
Maybe
parallax.
more RO or
audio.
less RO, one of the.
So try less RAO. We may have to go LAO then.
Yeah.
And accept.
I just
And
go
if you-
LAO.
If you go less RAO, you then start getting over the aorta as well. So you might as well
I think we'll accept this
go
view.
more
This one is
LAO.
excellent.
Yeah.
Okay, so Tim, show more LV, please. I think this is fine. Is everybody in agreement?
Looks good.
Just centralize it, make it in the center of screen to see up and down.
I think this is probably fine. Okay.
I think the pigtail is good position. Yeah, it's in a good position.
Yeah. And we have a good position of the pigtail catheter just above the prosthesis. We're ready for injection? Yeah?
Yeah.
Inject, please.
Very nice.
I don't see any leak.
Yeah.
And you did a good job. Look at the shallow implant that you have. I just congratulate you on that. What the CHB was, it seems that it was inevitable because you couldn't have done it to a better perfection than what you've done. Anything less than that would have been had other aspects of.
Yeah, but this is a caudal 38 or what it was this one? What is the view number?
This is caudal 38.
Yeah, so it's not actually give you the depth and it's like this. So either we go LEO 30 or the cusp overlap.
So let's just go, I want to go over that injection of yours while you were positioning the valve. I think that's an injection which we didn't want to disturb, but it's always much more educational to debrief ourselves on that positioning. So let's go to that.
Yeah. So as you noticed, Dr. Hatem just immediately asked us to deploy because the patient was a little bit hemodynamic unstable.
And there was one before that as well.
Yeah.
Can we just
one before?
Just go to while you were positioning it, and I don't know. Yeah, that's
this one. Here.
Okay. So here's the question which came up from the audience, and the question from the audience has to be addressed around this.
Could you please explain the octa alignment technique?
But this one is not octa-core, this one. So the alignment,
it's a Myval, they didn't do that. But, someone, and I don't have the name, was not very happy with the fact that it was truly coplanar. And you can see that the cusps are not aligned. So the coplanar angle is a little off, need more RAO and a touch caudal because as you can see that the non-coronary cusp is really protruding out.
Yeah. So I think when we took this view, the cusps were reasonably aligned for us. I understand that there is a little bit of disparity. One of the cusps is a little off. We are also mindful of the fact that this patient has chronic kidney disease and impaired renal function. So we didn't want to overuse contrast and decided to, accept this view, maybe a little modification in the view at the time of implantation.
So what I find it, like easy with little amount of contrast is to keep the big tail in the right coronary cusp, and basically you just use 5 or 7 or 8 cc at 1,000 or 900 psi. You can look at it. You will see all the 3 cusps clearly. But if you go to the non-coronary cusp, you're gonna need large amount of contrast to see all. So what usually I do, I keep the big tail in the right coronary cusp. Just make sure that I have a decent 3 coplanar view. Then I go to the non-coronary cusp and I do my cusp overlap. And when I go to the cusp overlap, I eliminate the parallax in this view. I make sure that I see the radiolucent line clearly, before I say this REO code or cusp overlap view is a decent, view to see the level and the depth of the valve. So it is very important to eliminate the parallax in the REO caudal to look for the actual depth.
So let's look at, there were two aspects that one sees here. I hope you're looking at the frame rather than the markers on the balloon, because we rarely are ever able to center this valve to the balloon markers. And my second aspect would be removal of the parallax from the valve frame at this point. So two aspects which are there, making sure that you are well co-aligned, as well as removal of the parallax from the valve frame. See what happens during balloon implantation? You did a great job. You're not even looking at that aspect. We just started learning a bit more from this debrief, that's all. And I'm the panel can give their experiences around it, because I personally thought that you did a great job. Yeah. Anything better than this may not be better.
Yeah. No, there's always a chance to optimize the.
You were 80-20, and it's certainly in this projection that you're doing, and you were expected to be ending up at 90-10 or pretty much 0.
It's very, actually, it look 80-20, but you have to eliminate the parallax before you say 80-20. Very important, because as far there's a parallax, you are a little bit deceived.
Sure, yeah.
So I suppose to understand where we landed exactly, we could try and do one more injection in the implantation view, modify it to remove the parallax, and see exactly where we are.
I thought you did that fairly well. I mean, you don't want to give more contrast. You've got a good result. Yeah. You're not going to undo anything.
Yeah,
no,
absolutely.
So I don't think you need to give. You've got no gradients. The pacemaker, I believe, was inevitable.
No.
And almost inevitable.
Yeah. So the gradient was very high at the beginning. So anyone would mitigate that calcium, or to avoid such things, the patient go hypotension when the valve cross, by doing some pre-dilatation. Andreas?
Well, I think the calcium score was not very high and the gradient was acceptable, so we would probably have directly implanted the valve in this case. I used those criteria. If I have a very high gradient, if I have a fibrotic valve, if I have a very high calcium score, then we would automatically predilate. But in a case like that, not.
Actually, I wouldn't predilate, especially if there is a small calcium. The other thing, the lower half of the valve is closed cell, so the radial forces are enough to overcome that calcium.
So there is a question about coronary. Are you do coronary access, like using left and right jetkin to access the coronary, to make sure in the future it's easy to access? I think with such Abdurrahman, what do you think?
Usually with the balloon expandable, we would not worry unless the coronary is low seated and the sinus is small. If the sinus is small, large, and the coronary even the coronary is low, no worry. But if the sinus is small and the coronaries are relatively borderline or low, probably we prefer to push the implantation down, because the pacemaker is a therapy, is not a complication. So and the patient is at risk by any means. It's atrial fibrillation or right bundle. He's at risk. 80 years, he may need pacemaker with or without our valve. So we are treating the pathology, and the conduction abnormality probably is a pathology which requires treatment. But the checking the coronaries routinely for acceptable anatomy and reasonable future access with the balloon expandable, it's not usually is not difficult.
So I think that was a great case, great live demonstration. We would let you go off the screen, continue our session, because we know that you've got to shift over. The case for the next live case, and we want to give you time for that. So please go ahead. I think you've done a great job.
Thank you, everyone. Thank you. Let's put the wire through. Yeah. Can I get
So now, we should move ahead so that we can have more discussions towards the end. We've had input of all, unless I can have any last comments from a panelist to say, would they have done anything differently? Please go ahead.
Actually, the Safari wire, it's among actually the softest wire used for TAVI. It's a range. Safari is the least stiff, and then the Lundquist is at the other extreme, and in between is the Confida and Bachmeier. Super stiff comes even stiffer than the Confida, and the Amplast stiff is below less stiffer than the Confida. So the lowest and the stiffness is the Safari wire. So it's very safe and to be used. The other thing, there is a wire on the market now. It's called Safi wire, where we can pace, you can get the hemodynamics, and you can implant the valve through it.
Thank you. We will move on and have our next talk here, the long-term clinical follow-up of Myval transcatheter heart valve. Dr. Almogheri, over to you.
Good afternoon. We have the initial, I will share with you our initial experience with the Merrill valve. So we started in the 2019 with the few cases, and we have the maybe this over 5 years follow-up. So since the transcatheter valve started and being started for the high risk or prohibitive risk for surgery, now is moving towards the low risk and also younger generation. So the valve transfer valve therapy for the aortic valve is well-established therapy. And the currently many platforms with a successful short and relatively long term, up to 10 years. It's gaining more weight with the evidence over time and more platforms ongoing. And now we are discussing the long-term management or lifelong management and moving more towards the short frames more than long frames. For the future, the expectations, and the Merrill unique for them is the intermediate and the extra large sizes among the balloon expandable valves until the competitors comes with this on board and with the continuously successful journey. And we have seen it from the introduction, the valve structure, and it's been explained by Dr. Ashok, and the studies being published since the CE mark initial study publications, and the result, and the followed by the evidence to support the therapy in general, the concept in general, and this device in particular, with favorable hemodynamics. And the hemodynamics in Merrill comes from the suture line, the commissural line. The commissural line comes at the frame itself. This which gives the device some hemodynamic comparability to the supraannular platform. And probably it's being recognized and implemented in the future to improve the hemodynamics for the small anatomy to make it more favorable for the intraannular valves. And we heard from the compare study to compare the non-inferiority of this platform to the contemporary platforms. And from the perspectives of the generally what had been reported regarding the pacemakers and the others, probably they share, all platforms share the same risk factors: the atrial fibrillation, right bundle, abnormal conduction or abnormalities, the implantation depth. This is probably is common among the things. And we noticed with the more bleeding with the in compare trial, I don't know, is it maybe locally from the puncture site, and there is no more details about that. And regarding our experience, we implanted the initial 7 cases. We implanted more than maybe 70 or approaching 100 cases of the middle valve. But the initial, which completed 5 years, is the 7 cases. And we had a favorable result, is reasonable with the almostly comparable to the what had been in the trials, the baseline characteristics of the patients and the baseline gradients, baseline symptoms, and also the acute results. The success was at that time was 100% at the implantation level, and there is no intra-hospital hospital mortality at that time. We had a patient who had later on minor stroke, and he had been admitted with the non-cardiac condition, which is complicated cholecystitis and cholangitis, and he passed away a few months later with the complicated cholecystitis. So we had in the follow-up, so the main follow-up is the patient symptoms, the hemodynamics, and the echo findings, which show and the patient symptoms is not significant, the sustainable result. And the gradient, the main gradient remained in the range of from 10 to 16 mean gradient by the echo follow-up until the last echo follow-up, and the patient still following with us with no events. No patient admitted with the cardiac-related symptoms, and this is their echo results, and it's a sustainable result so far the last 5 years. And probably will continue the rest of the patients to follow them and to report the subsequent hemodynamics on the echo findings in the future. And as been mentioned already, for the expansion of the indications for the balloon-expandable valve, and this platform in particular, similar to the other platforms, involves the bicuspid valve, and being published already data on this. And the aortic regage also is being reported in the literature. Low-risk patients with aortic stenosis also been. Large annulus, we implanted up to 900 millimeters area, and valve-in-valve being used also for both in the balloon-expandable and also implanted in the self-expandable valves with a variable success rate. And thank you very much.
Thank you very much. We do have time for a question. My suggestion is, yes, we're putting together all our earlier cases done in 2018-19. Remember, we started it as a first-in-human study, 2017. We're putting our cases in together for a long-term follow-up. And I think a 5-year follow-up, which could be multi-center, multi-regional, would be a great collaboration, because that's now at the moment happening as a...
we agree. Probably there are centers can be on board also, come involved.
That's right, and we look forward to that sort of collaboration. Yes, Andreas?
Yeah, of course, the 2 trials that we've just heard about, the Landmark and the Compare, they will go out to 10 years. We will have really large series with long-term follow-ups. But at the moment, this is the kind of data we need to reassure us that everything will be okay and that there is no signal of safety or deterioration. This is exactly what we would expect, and for that to be continued.
So again, partnership will happen, because we're collecting that from India as well, and you're going to be a part of that collaboration. Any questions, anything, any comments? If there are none, we just move on to the next talk, which is valve-in-valve interventions case series from Khalilpur Ehsan.
Dear friends and colleagues, good afternoon. This is a great honor to be here. I am presenting our center data about the valve-in-valve procedure with Myval THV. We started TAVI like 10 years ago, and in the last 4 years, we have performed over 800 cases. And if we add some cases which we has been as proctor, that's gonna be over 1,000 cases in the last 4 years. We implanted the first Myval case in September 2020. And after that, we have implanted in our center like 348 cases. The first case was severe symptomatic AS, 71 years old gentleman, and with preserved LV systolic function. I just cropped the images from the first patient, which shows the date over that September 2020. We implanted 27.5 valve, and that was the final result. After 4 years, 2 months ago, the patient came into the clinic, and this is the follow-up data. No regurgitation, mean gradient of 16, and the patient was doing well. In our center, we have performed 91 cases of valve-in-valve with all platforms, most of them in pulmonary position because we are a referral center for TF patients. And we have performed 38 cases with valve-in-valve with Myval, which is 41% of all cases. Why we have chosen the Myval for this procedure? Because it is really got decent flexibility, gratifying trackability, prodigious maneuverability, passable pushability, staggering skirt, capacious sizing. We know that there is no need to add or less CC for this valve, predictable for shortening, and fully retrievability before deployment. Is it feasible in any position? Yes, it is really feasible. This is the summary of all positions: aortic, mitral valve-in-valve, TV, and pulmonary. I'm presenting 4 cases. The first case is a 72-year-old gentleman with prior history of CABG and biprosthetic AVR with Hancock 227, 9 years ago, which presented with dystonia exertion. Workup revealed severe aortic BVD. This is the fluoroscopy in chest X-ray for biprosthetic. This is echo appreciating severe degeneration, severe transvalvular and paravalvular leakage. And this is the CAT scan before the procedure, which shows inner ID of 24-27. Coronary access was an issue in this case, and VTA, VTC of more than 6 millimeter. This is the femoral access, which is acceptable for performing transfemoral. And we know this application for valve-in-valve developed by Vinny, which shows every data we need for biprosthetic valve. In this case, Hancock 2 shows non-fracturable stent ID of 24, and it is suggested to go for balloon expandable of 23 or 26. For this case, because we had 25 millimeter of ID, we went for a 26 Myval THV, and this is the deployment and final angiographic result, which shows mild paravalvular leakage and good acceptable deployment. And this is the post-procedural assessment, which shows mean gradient of 11. The second case is 63-year-old lady with prior history of rheumatismal heart disease, which underwent biprosthetic MVR 11 years ago with EPIC 27, and presented to clinic with recent symptoms. An assessment showed severe degenerative BVD and good space of the prior valve with the LVOT, and echo demonstrating increased gradient, severe transvalvular regurgitation. And this is the data about this valve, which shows EPIC 27, a stent ID of 25, and suggested Myval or other balloon expandable THV with size of 26. We also assessed the new LVOT, which shows over 200 millimeter of square, so we weren't worried about this, and we went for the procedure. We performed the transseptal puncture, wired, double wired to had no issue in the passage of the valve, pre-dilated the septum and also the valve, and with a slow gradual inflation, we deployed the valve and final angiographic result, which shows a great result for this severe degenerative bioprosthetic. And also aleocaudal view for asymmetric final expansion of the valve. And this is the post-procedural assessment, which shows acceptable final result. Case 3, another rheumatismal heart disease patient in tricuspid position, EPIC 27 again, and echo assessment, which shows degenerative, again, the same data with prior mitral, and we wired the valve, pre-dilated, and final deployment of the valve, which shows a great procedure, and this is also for total fluoroscopic time of 8 minutes. And this is final result with a mean gradient of 2. And another case, pulmonary position, a tetralogy of fallow case, and this is the fluoroscopic mark, RV dilated, increased gradient. And the bioprosthetic in this case was mitral flow 25, which suggested a 23 valve, and also wired, pre-dilated, and final deployment, and smooth passage of the valve through the RVOT to the valve, and final angiographic result with the mean gradient of 2. So we believe Myval and its latest iterations are safe and suitable THV for valve-in-valve procedure. Its flexibility, trackability, and passability makes the procedure much simple. Its skirt is definitely enough for prevent paravalvular leakage, and we think Myval proved to be a durable and reliable balloon-expandable THV. Thank you very much.
Thank you. Are there comments here? Yes.
So very nice cases. Just a question regarding fracturing. When do you consider fracturing? Because at least the mitral flow you could have considered.
Mostly in case of aortic position, we need to modify the valve size because of the final gradient. But in this case, we had a good, actually, for our case, good final gradient. But sometimes we need to perform it pre or post implantation. It depends on the situation. And if it is mandatory, we will perform it with a true balloon or Atlas Gold balloon.
Mitral flow and trifecta, they are not fracturable. I don't think they're fracturable. Mitral flow, you cannot.
Yeah, you can, certainly. Both of them. Just use enough pressure. I think that the point is just that if you want to fracture, you should decide up front, because often it increases the valve size. So you should decide before you initiate the procedure if you want or not.
You know, that jury, I guess, is going to be a very controversial one, isn't it? Upfront fracture versus post-fracture?
No, it's more this, you need to decide if you fracture or not, because if you fracture, you can actually implant a one size larger valve.
Yes, you would need a larger valve.
But mostly you do the fracturing after implantation, but you have to decide of the valve choice before you initiate the procedure.
Right, that's what you're saying. Nicholas, you just had...
No, I just wanted to ask you for some advices and for our colleagues in the room regarding the mitral valve-in-valve, valve-in-ring, valve-in-mac, where with the existing catheter, you could have sometimes a lack of pushability. Mm-hmm. So we saw in your case that you used the body wire technique. Can you elaborate a little bit on that?
Before performing the procedure, we like to predilate the septum with 14 or 12 millimeter balloon. And if we put another wire, that's gonna just push the septum away and you could go. It is pretty predictable, smooth movement of the navigator with the valve implant crimped over that. After 20 cases of mitral valve, we actually haven't had any issue to passage of the valve through the valve. Also, you need to sometimes curve like the valve which is known as Redwood curve, because Simon is pretty interested in this curve. It is gonna just help you, or you could just anchor with a snare, right Judkins inside of the LV to put the tip of the wire to make you, just give you some more support to pass it.
Maybe you can push the wire to the ascending aorta through the aortic valve, which can go easily forward with the catheter, whatever the catheter you prefer, even for French, until you get to the distal. Then bring your stiff wire, and it will work.
You know,
Yes,
please.
Yes, I want to say that especially for tricuspid valve recently, to be honest, I think the aortic valve is not enough for tricuspid. And we have some experiences with valve thrombosis after a while after. And recently, we tried to deploy the bigger valves, especially if you know that the valve is fracturable or extensible. And recently, we tried to have 30.5 or 32. We add some value, especially in valves that we can expand it. And the result recently for tricuspid is better than the previous one. And as Ehsan mentioned, I think the priority of Myval for valve-in-valve, especially in right one, when you work in pulmonary, in tricuspid, or mitral, is flexibility of the balloon delivery is very flexible, because sometimes, especially when you use shorter sheaths, sending the rigid valves is hard, for especially in RVOT, that this patient had history of surgery, very wide RVOT, and I think Myval in this view is a good valve.
Any further comments from the panel? I mean, I think before we end, and we're just about to end, there was a question which we should address, and that is octa-aligned technique. There was a question which said, what's octa-aligned technique? How's it performed? And just briefly around that, and that's just answering your question, is that it's CT analysis. CT analysis tells us the origin of the right coronary artery. Now there's a clock on the crimper. There's a dial on the crimper. We aim for the commissure of the valve that we mounting on the balloon to be placed at where the right coronary artery arises from. That goes into an assumption that as the valve goes across the aortic arch, it will invert itself 180 degrees, and the commissure will be exactly opposite to the origin of the right coronary artery. If that commissure goes opposite to the origin of the right coronary artery, then, as you know, the two coronaries, which are 120-degree aligned, now this is going to be, this valve, the commissures are going to fall in between the coronaries, and therefore automatically aligned. That has to take into account, must take into account, it's a supposition that the two coronaries are arising at an angle of 120 degrees, but it may not be anomalous origins. Therefore, you can rotate the clock in a manner that you, what you call commissural, you can malalign yourself to the commissures in a manner that you still keep it away from the origin of the coronaries. Bicuspids also, it is possible to do commissural alignment. It just relies on that principle. It's 80%, it's more than 80% likely that you'd get a commissural alignment. With those words, I think we're ready to end up and wrap up. We're getting to that level. I think this has been a great session. In fact, it's been a privilege that it was 2018 when at the PCR, I presented at the late-breaking trials of Myval 1 study as a principal investigator. 8 years, in 6 years, we moved the clock in a huge manner with some of the greats sitting around this table and in the audience, where we saw just tremendous cases from Myval, such science, trials, prospective randomized trials, and of course, great experiences from around the table and across the world. So I'm pretty happy today that a valve produced in India was for the world and prove itself to the world in multiple regions and in hands of numerous across the world. And therefore, it's a privilege that we keep moving the science along, keep perfecting. And as we go forwards, and Merrill brings up new innovations, especially with the Octacore and the OctaPro, which we started which we launched in India and started its implant, we see a great future for making TAVI affordable, accessible, and giving quality outcomes to the patients across the world. Because finally, at the end of the day, there's certainly limitations of finances, even in the most developed countries, certainly, and therefore we need to address those issues and have more valves available to us. With those words, thank you very much, all of you, for being an integral part, both of this session and the partnership. Thank you.